this PowerPoint basically based on question and answer, and we are going to learn the information from every question. The first question here, the frequency for cervical scanning depends on patient and her age. What are the longest recommendation time interval between cervical scan for the patient whose age is 21 to 65 years age? This question I choose for you because of something hidden information in between this question. Examiner mentioning the time 21 to 65 years age. Okay, and also examiner asks the longest gap, recommendation time intervals between two cervical scanning. So cervical scanning is important to prevent the cervix carcinoma or CS cervix. There are options 1 year, 2 years, 3 years, and 5 years. The correct answer 5 years. So the longest gap recommended. What are the explanation? Women is 21 to 65 who have a cervix should be scanned for cervical cancer. This 21 to 65 mentioning in this question. And also scanning interval every 3 years. So why not we choose 3 years? Because we know that the scanning interval every 3 years should take place for the women who has age 21 to 29, but my question showing 21 to 65 years. One option. Second option, women age 30 to 65 years take place every 3 years if only cytology performed. So if cytology is something abnormal, then you also tell them every 3 years you have to come and do it, right, to protect your cervix. But our answer is 5, the reason being 31 to 65, and also you say the every 5 years if cytology plus herpes simplex virus scanning take place. So frequency for scanning depends on the patient age and her age, but what are the longest recommendation? If patient have no problem, no cytological abnormalities, it should be the 5 years. But if patient is 30 to 65, also 3 years, if they have any kind of risk factor is there. So when you read this question, it is important to figure out what examiner basically asking. Here we can see a guideline. It's called cervical cancer scanning guideline. Under the 21 years age, under the 21 year, you do not need to scan, right? You do not need to evaluate. But when you 21 means you are sexually active. I know before 21, so many exposure histories present, but we are talking legally. 21 to 29 years of age, the first PEP test is important. Also, PEP test every 3 years. Every 3 years you have to do it. If you have no risk factor means if you have a cytology change in cervix, or if you have a multiple sexual partner, right? Or if you are previously exposed herpes simplex viruses, or when patient is 30 to 65 years age, PEP test every 3 years, or PEP test and herpes simplex virus every 5 years. If you're 65 years older, no test needed if negative history of last 10 years, right? So usually it is every 3 years, but after 30 to 65, if you have any kind of risk factor, it should be 3 years. Otherwise, it should be 5 years. And after 65, you do not need. Let me go to the next question here. A pregnant patient is likely to have. Again, I want to remind you, every question we are going to learn a new information. So this said, venous hum murmur and S3 present, mitral stenosis and S3 present. Number 3, mitral valve prolapse and S4, aortic regurgitation and S4. So this question said, pregnant patient likely to have. Aortic regurgitation is a disease. It is not necessary a mother get pregnant and she has developed aortic regurg. Mitral valve is a disease, or mitral valve prolapse is a disease. It is not, there are no survey, or there are no evidence when a girl gets pregnant and she developed mitral valve prolapse. Same as mitral stenosis, no way. So this is basically 3 diseases, right? So murmur may be sometimes present during the pregnancy, and it is called hum murmur. Okay, so many change occur in cardiovascular system when patients are pregnant. So like blood pressure change, cardiac output change, pulse rate change, right? Volume change. So nearly all pregnant women have a venous hum murmur, a higher basal heart rate, louder heart sound, and systolic ejection murmur are usual. S3 is commonly present, probably related to increase the fluid. S4 is very uncommon to her here. Mitral stenosis and aortic regurgitation are diastolic murmur, and these are abnormal in pregnant patients. So from this question, what we learn? We learn when a mother gets pregnant, she maybe develop murmur, and this murmur is called hum murmur, H-U-M. Another point we learn, if any patient present with mitral stenosis or aortic regurgitation, their murmur is diastolic murmur. Next question. A common early findings in patients who have chronic aortic regurgitations. So if patient have aortic regurgitation, what should be present with this patient? And hypertrophied left ventricle, aortic fibrillation, pulmonary congestion, and low systolic blood pressure. So my patient have a aortic regurgitation. So if patient has aortic regurgitation, what are the comorbidity or what are the other findings is most possible? It is answer is hypertrophied left ventricle. So left ventricle constantly get under pressure and hypertrophied is occur. So left ventricle enlarge as a blood regurgs from aorta, right? Regurg means backflow. Atrial fibrillation is not a typical or usual aortic regurgitations, since either atrium is affected, atrium means atrium and ventricle. Pulmonary congestion is seen later in the pathogenesis in AR, means aortic regurgitation. The blood pressure in patients with AR is characterized by an elevated systolic and decrease the diastolic pressure. What the next? Next question here, typical description of sciatica is, right? Number one, deep and aching pain or worse with lying down, burning and sharp pain, and precipitated by coughing. So sciatica basically a severe pain that is radiate from back into the hip and also outer side of the leg caused by compression of the sciatic nerve. So sciatic nerve, let me show you. So like sciatic nerve, it distribute our back and lower extremities. So which nerve root is get involved and which nerve distribute what area, that area get infected. I said severe pain, and that radiate from the back into the hip and outer side of the leg and caused by compression of sciatic nerve, but it depends which nerve get involved. So if the nerve root is number 4, pain supposed to come back, lateral side, and come anterior side of leg. If root 5, it should be back side, outer side, and leg. If S1, it should be totally back of the thigh, back of the knee, and calf muscle. Same time, patient complain of numbness. So if number 4, numbness just front of the knee, number 5, numbness in the lateral aspect of the legs, and also 3 middle finger of the feet. If sciatic nerve, sacral 1 involved, calf muscle, and foot. So again, let me read it. Sciatica is irritation of the nerve root because of compression. Patients usually complain of sharp, burning pain that can be accompanied by numbness, tingling sensation, radiating pain down to the posterior, lateral, anterior aspect of the leg. But which area get involved? It depends which nerve get involved, right, my friend? Also, disc herniation. So everybody know it is disc herniation, but you are very special. You are going to get your RN license, so you know it is actually sciatica. So you have to know what are the difference between these two. So which could cause sciatica? So disc herniation can cause sciatica, but sciatica is not a disc herniation, and increase the pain with coughing, sneezing, also Valsalva maneuver. So what we learn from here, what are the most common sign symptoms of sciatica? And the pain is burning and sharp. So if you ask me what are the other sign means patient complain the pain that radiate from back into the hip, outer side of the leg, as I told you, and leg pain, which is more common in the inner side of the thigh. And also, patient say, my pain is constant, not intermittent. And also weakness to the lower leg, pain, numbness, and difficulties while moving the legs. And pain that is worse when patients are sitting, right? Also, patient complain tingling sensation along the legs. Next question here, which symptom listed below a typical of depression? Difficulty of falling asleep, or patient make a sound soaring, or early morning weakness, early morning wakeness. So they wake up very early, like 4 a.m. keeping late night hour reading. So there are 4 question answer option basically. Number 2 and number 4, no way to be answered. Difficulty falling asleep, maybe, or early morning get up is maybe. Why not number 1 is the answer? Why number 2 is answer? Easier to say, the patient who are depressed or major depressive disorder, they have a common complaint. I get up very early morning, means around 4 a.m., 4:30. But difficulty of falling asleep is a common general problem for all psychiatric patients, like anxiety, stress, other psychosis, and also depression. But get up early morning is more specific for depression. So sleep difficulty is a common complaint among the patient with depression or the psychosis. Patients with difficulty falling asleep are often anxieties, frequent walking or early morning waking or get up are complained by many patients with depression. There is no agreed on physiological explanation, but this is a common symptom. Next question. Group A, Staphylococcus pharyngitis means inflammation of the pharynx, and it is characterized by a single symptom, can be accompanied by abdominal pain, usually does not have exudate symptom. It is commonly accompanied by an inflamed uvula. Uvula is one of the part in our larynx and pharynx. But here, the question which chose, it is not like it should be the answer, but still it is the answer. Why it is the answer? Group A, Streptococcus is usually characterized by multiple symptoms with a sudden onset. Sore throat is usually accompanied by fever and headache. GI symptoms are common too, like nausea, vomiting, abdominal pain are usual. Even without treatment, symptoms usually resolve in 3 to 5 days. So, what we learn from here? We learn it is not look like the answer, but it is the answer. So we learn here, if a patient has a bacterial infection, particularly Rebecca field, group A, the Streptococcus infection, patient present with fever, patient present with sore throat, but they also have the presentation of GI symptom like nausea, vomiting, and abdominal pain. What next? Next question here. A 65 years old male present with a 12-hour history of an extremely painful left red eye. So my patient is 65 years old, right? And patient complained 12 hours history of extremely painful left red eye. The patient complained of blur of vision, hollows around the light, and vomiting. It begins yesterday evening, and on exam, the eye is red, tender, and inflamed. Cornea is hazy, and pupil react poorly to the light. The most likely diagnosis of this patient is acute angle glaucoma, increased intracranial pressure, macular degeneration, and detached retina. So this question came from eye, but why is acute ankle glaucoma is the answer, why not macular degeneration or detached retina? Let me explain the explanation. So the clinical presentations of a patient with acute ankle glaucoma is an patient has presented the age greater than 60 years, right? My patient is 61 years. Patient present with eye pain, blur of vision, nausea and vomiting are common. Pain is usually present when intraocular pressure raises rapidly. So in acute angle glaucoma, this is the most common presentation. Patient has a severe pain and also produce the conjunctival redness. Symptoms are more common in evening, and they said vomiting, and it begins yesterday evening. So acute angle glaucoma, most of the common pain at evening when light level diminished and mydriasis occur. And the chronic angle glaucoma, pressure raised slowly, but it is an acute onset. So suddenly pain started, right? And definitely if untreated, it lead to the blindness. Next question. What is the usual age for vision evaluate for the young children? What are the usual age? Answer is the 3 years. So this is the information we learned from this note. A baby or a newborn, when born, when they used to check their vision, when they 3 years old. So initial vision scanning should take the place 3 years age. If the child is not cooperative, the scanning should be attempted 6 months later. If the child is still not cooperate, then 3.5 years is okay. It should be attempted at the 4 years. Generally, children are cooperate at the 4 years of age. The usual vision 3 years old would be 20/50. And next question, we are going to see here. A skin lesion, fluorescence under the wood lamp. What microscopic findings is constant with this? So you see, this is the patient, and in fluorescent test or fluorescence wood lamp test, the picture look like this. You can see the picture. It is very complicated. Actually, no, it is very easy exam, and non-invasive technique. It is not a harmful, but it would be very easy to find out microorganism affected in the outer layer of the skin. So microscopic findings consist with this. So skin lesion fluorescence under the wood lamp. So what kind of cell we will be get it? Clue cells, scabies, hyphae, and leukocyte. So we will get the hyphae. Hyphae means it is the antifungal. So wood lamp always emits the ultraviolet light when turning on. If an area fluorescence under the wood lamp illumination, the fungi or fungal, sometimes bacterial infection should be suspected. Hyphae are associated with the fungal infection. The test is most effectively performed in a darkened room so that fluorescence can more easily identified. Some example, last 2 years, because of the COVID, we do hand wash our again and again. But after the hand wash, if we check fluorescence under the wood lamp test, if any organism still in our hand, it should be visible. So what is wood lamp test? A wood lamp test exam is a procedure that are used to trans illuminations and also to detect the bacteria or fungal skin infection. It also can detect the skin pigmentation disorders such as vitiligo or other skin irregularities. This procedure can also be used to determine if you have a corneal abrasion on the surface of your eye. Next question. A positive Tandlberg test could be used to identify a child with. My friend, don't forget Tandlberg position. But this is the question, Tandlberg test. It is not a position. Okay, they're two different things. So Tandlberg test we will do for scoliosis or Osgood'S disease or shifted capital femoral epiphysis. So we learn from this note, one of the tests is called Tandlberg test. So it is the normal, but if any abnormalities in the hip joint, it should be look like this. So hip joint, one part go down. So asking a child with a complaint to hip pain of to stand on affected side is how the Tandlberg test is assessed. So when they sit and walk, they complain about the pain. A positive Tandlberg test occurs when standing on affected leg causes a pelvic tilt, such that the unaffected hip is lower. Also, this can be assessed and observed in the children with a slipped capital femoral epiphysis or leg cap part disease, also developmental dysplasia of the hip. And sometimes in some elbow problem, it's a common ligamentous injury in young children. A radial head become subluxed. It is in elbow problem. Displacement is usually easy to reduce, and also Adams forward band test is used to assess for scoliosis. What else? The Osgood'S disease is associated by the assessing the pain with the palpate, the tibial tubercles. Next question. So a patient, 86 years old, and also functions independently. He has hypertension, hyperlipidemia, and benign enlargement of prostate, and also flare-up of gout. So you see, comorbidity is gout, BPH, hyperlipidemia, and hypertension. His last colonoscopy was 76 years age, almost 10 years before. Colonoscopy basically imaging test of colon to detect any abnormalities and using the colonoscope. What should be advised about having a colonoscopy? Colonoscopy is performed method for scanning older adult. It is not right. And colonoscopy is ill-advised old adult. No, it is not. It is not advised in this patient at this age time because he is 76 years old, and he is 86 years old, and within last 10 years, he already done this exam and there are no positive findings. So scanning is not necessary after the age of 80. So the correct answer, it is not advised at this patients at this time. Why number 4 is not an answer? Because it is for general, but this is more specific for my patient. And other things is general, I do not know. Every patient is individual. Maybe this patient has a high risk. Maybe they need, who knows? Prior to any scanning test such as colonoscopy, consider must be given the patient's overall health status, colorectal cancer rates, and also desire to pursue the treatment if cancer or disease is diagnosed. United States Preventive Service Task Force, it is called USPSTF. Okay. American College of Physicians and also American College of Gastroenterology do not recommend scanning 86 years old for colorectal cancer. As a general rule, the patient with life expectancy for less than 5 to 10 years should forego colorectal cancer scanning by colonoscopy. Colonoscopy enables the examiner to visualize the entire colon and is superior scanning tools for colorectal cancer. But there are significant risks for bleeding and perforations of old adults, so it is not recommended for them. Additionally, the colon preparation can produce massive shift of electrolyte that can increase the likelihood of arrhythmias, heart failure, weakness, and fall. So it is good not to go for patient who is 86 years old. Next question, Mycoplasma pneumonia is diagnosed by exclusions, an uncommon respiratory pathogen, only identifiable on chest X-ray, a disease with extrapyramidal manifestations. So, Mycoplasma pneumonia, right? The correct answer, they said, a disease with the extrapyramidal manifestation may be present. So it is uncommon respiratory pathogen. It is not uncommon. Mycoplasma not identified by chest X-ray. Mycoplasma is identified by clinical presentation and culture, okay, cough culture. But by the chest X-ray, it is possible to see if any patient have a previous history of mycoplasma or tuberculosis, and also mycoplasma if affected the organ like lungs. So mycoplasma is atypical pathogen and produce atypical pneumonia. But which one is the typical? It is the organism which is called mycoplasma that is causes the TB or tuberculosis in the lungs. But atypical is mycoplasma pneumonia. It can be difficult to diagnose because symptoms can be vary and involve multiple body systems. It is called extrapulmonary tuberculosis. Infection with mycoplasma may present with a normal white blood cell count, maculopapular rash, GI symptom, tender joint in act, also cardiac rhythm disturbance. Respiratory symptom may not be pronounced because this is the atypical mycoplasma. If it is typical mycoplasma, that should be present in tuberculosis like coughing or, like I said, weight loss or evening raise of temperature, night sweat, pain in the chest, loss of appetite also, or cough with blood in sputum, persistent cough with more than 2 weeks. This is the typical presentation of tuberculosis or TB, shortly said, right? Basically, tuberculosis or typical mycoplasma, very contagious infection caused by bacteria, and that mainly affected the lungs, but can also affect any organ, including our brain, bones, and spine, even kidney. But atypical one not involve lungs, so presentation is very vague. On chest X-ray, there are some unique findings with mycoplasma. This include thickening bronchial shadow and also atelectasis, and these are more likely occur in lower lobes. And next questions. A patient taking SC inhibitor should avoid. So if I need to take SC inhibitor because of my high blood pressure, what I have to know? I have to know the SC inhibitor increase my potassium level. It can cause hyperkalemia. So I will not take potassium containing food. But we are a healthcare provider. We have to educate our patient, because doctor prescribe the medication, but doctor will not explain everything to the patient, but you should do because you are RN. Okay. So potassium supplement. Also, SC inhibitor potentially can produce hyperkalemia because its mechanism of action is to spare potassium. Spare means reabsorption, retention in the renin angiotensin adolescent system. If potassium is taken in the form of potassium supplement, the effect will be additive and risks of hyperkalemia. Hyperkalemia lead to arrhythmia and patient die because of heart failure. Clinical manifestation of hyperkalemia. First of all, normal potassium levels is 3.5 to 5.0 milliequivalent per liter. So if it is less than 3.5, hypokalemia, more than 5.0, hyperkalemia, both is bad for your heart. Both can lead to dysarrhythmia, and dysarrhythmia leads to heart failure. So what are the presentation if I have hyperkalemia? Neurological presentation, I will complain, I feel weakness, sometimes paralysis or respiratory failure at the very terminal stage, right? So before go respiratory paralysis or respiratory failure, as a healthcare provider, you can evaluate by check the EKG. What are the changes take place in EKG? If patient had hyperkalemia, we will get a tall peaked T wave and also with a shortened QT interval. So if the T wave is too long, you will find it out patient have hyperkalemia. Also arrhythmias. GI presentation, patient complain nausea, vomiting, and diarrhea. Next question, which immunization may be safely given during the third trimester of pregnancies? You see, third trimester pregnancy, which immunization is okay or safer? Varicella, Tdap means tetanus, diphtheria, pertussis. MMR, hepatitis A and hepatitis B. So what we learn from this question? We learn Tdap or diphtheria, tetanus, diphtheria, pertussis is safe for pregnant mother. Which one is not safe? Varicella is not safe. MMR, measles, mumps, rubella, not safe. Hepatitis A and B, not safe, right? Let me make it easier. I want to tell you, live attenuated vaccine is not safe for pregnant mother. An example of live attenuated vaccine is varicella, MMR, and hepatitis A and B. Let me read explanation. Live viruses should not be given at any time during the pregnancy. So, my dear friend, if you have any kind of question, please don't feel hesitate to email me or text me. I will take more time to explain even what is the live attenuated vaccine, what is safe for during pregnancy or immunocompromised or during the allergic reaction. I will explain a little bit more. Therefore, MMR and varicella should never be given to patients known to be pregnant, right? So MMR, also varicella. So if I give live attenuated vaccine to mother, and most of them can cross the blood-brain barrier, and baby will born with the disease or infected. There are no pregnancy information about hepatitis A and B immunization, so it is good to avoid. But general recommendation to avoid this during the pregnancy unless the patient is particularly the risk hepatitis. Tdap is recommended by CDC for administration of pregnant patients in the 3rd trimester for every pregnancy, also regardless of the previous immunization status. Here's some note, how we remember which one is a live vaccine, right? Easy way to remember, Rome is my best place to go yet. ROME, R for rubella, O for oral polio vaccine, M for measles, E for epidemic typhus, I for influenza, M for mumps, B for BCG vaccine, and P for plague vaccines, T for typhoid oral vaccines, and Y for yellow fever vaccine, right? So they are live attenuated vaccine. They are not safe for pregnant mother, right? Another way to remember, boy love that cry. So B for BCG, O for oral polio, Y for yellow fever. And boy loves is live attenuated example. And it is the cry. D means typhoid, cry means chickenpox. It is actually varicella, right? Chickenpox. And R for rubella, I for influenza, M for mumps and measles, and E for epidemic typhus. So it is easy to remember, boy loves the cry. Next, here, little bit more information. Vaccine type and vaccine in this type on US recommended childhood immunization schedule. Like attenuated vaccine example, measles, mumps, rubella, shortly called MMR, varicella, it is actually chickenpox, influenza, but nasal spray one, it is live. And also rotavirus. So rotavirus can cause diarrhea, very bad diarrhea, right? Now, inactive or killed vaccine, this is polio and hepatitis A. Toxoid vaccine like diphtheria, tetanus, Also some subunit like hepatitis B, influenza, but injectable. This is influenza nasal. Hemophilus influenza type B, shortly called HIV. HIP. Also pertussis, pneumococcal and meningococcal vaccines. So next question. A 51 years old female present with a 2 centimeter palpable breast mass, and she showed, and how should this be evaluated to determine whether this is solid or cystic nature? So again, I want to remind you, every question is a new information we are going to learn. So if a patient present with a breast lump, we have to know it is solid or cystic. What are the good tests? It is ultrasound, not a mammogram. So most of the students get wrong mammogram because it's the most common test for evaluate the cancer in the breast or tumor of the breast. But ultrasound is good to differentiate it is solid or cystic. So let me explain. The diagnostic test of choice to differentiate the solid form of fluid-filled breast mass is ultrasound. Mammogram has a potential to evaluate the presence of mass, but it is not adequate to distinguish between solid and cystic. Next question. What are the earliest age that the average child should be avoid? So should be able to copy of triangle. Also know his color, count his finger. So what are the average age? Around 5 years. So when a boy or girls 5 years old, they are able to copy a triangle, they are able to distinguish the color and also counting the finger. Common developmental tasks for 5 years old include ability to draw a person's body, head, arms, and legs. Also recognized most letter and can print some. Known this address or phone number, address self without help, able to script also, too, and also play cooperatively and enjoy playmate company. So now let me go. Next question. A 4 years old is suspected to having developmental dysplasia of the hip, shortly called DDH. What test would be best assessed for this patient? I gathered this question because most of the students do wrong Barlow ortholani test. Why not this is the answer? Why this is Galanzi test is the answer. First of all, let me read this question one more time. 4 months old suspect having developmental dysplasia of the hip, right? What are the best assessment for this patient? Answer is Galanzi test. So Galanzi and Lee's test, limited abduction, also apparent high length discrepancy of better indication of DDH than instability after the 3 months of age. Question or try to get me. My patient is a 4 years old. If patient come to you before 3 months age, you go for Barlow and ortholani test. If your patient more than 3 months, like 4 months old, no more Barlow ortholani test. Then we go for Galanzi test, right? Let me read it. So after the 3 months age, we always go for Galanzi. Barlow and ortholani maneuver are physical exam techniques used to assess his hip stability in the newborn and also infant 3 months of age or younger. Weakness of this hip abductor of the affected side in the presence of unilateral hip dysplasia may be indicated by positive Tenderberg pelvic test, right? Also, Rombach test here. Rombach test is used to clinical assessment of patients with neurological problems such as disequilibrium or ataxia. So this test, we say Galanzi test. When patient disposition, we can say one is shorter than others, not equal. But this test for hip dysplasia after 3 months. But before 3 months, we always go for Barlow and ortholani test. Rombach test we do if patient have a disequilibrium or ataxia. Next question, a common strategy used to minimize the incidence of side effect when giving an older adult selective serotonin uptake. So common strategy used to minimize the incidence, the side effect if you give select SSRI for elderly patient. Number one, take the medication at bedtime and slowly to minimize the dizziness. Also prescribe a low dose. Take the medication with food. So always it is very, it does make sense. Always psychiatry medication, we will start with a very low dose, right? So principle that the employed when the prescribing medication for old adult start with a low dose and go slow. This should be employed when the prescribing SSRI2. Lowest dose should be starting point and prescriber must order even lower dose initially. Dose may be slowly increased until therapeutic effect are observed. Next, here, few information about the selective serotonin reuptake inhibitor, shortly called SSRI. Usually take time to start the activities. Full effect make delayed for more than 4 weeks. So you have to wait 4 weeks to see the effect. Increase the risk for bleeding in combinations with aspirin, NSAID, and warfarin. So SSRI do not give with aspirin, with NSAID, with warfarin. But some elderly patient has a comorbidity, so polypharmacy is a big issue. Monitoring for hyponatremia, monitoring for hypoglycemia. So AC inhibitor can cause hyperkalemia, but SSRI can cause hyponatremia, hypoglycemia. So educate your patient to adjust the insulin or metformin if they have diabetic. Check the compatibilities with other medication for drug and drug interaction. Potent inhibitor of hepatic cytochrome P450 isoenzyme inhibiting metabolism for other many other drugs leading to toxicity. What they are? It is TCA, tricyclic antidepressant, antiarrhythmia, neuroleptic drugs like haloperidol, and beta blockers. Risks for serotonin syndrome, like if you take with dextromethorphan, MAO inhibitor, TCA, or triptan together, may not be taken within 5 weeks to take the MAO inhibitor. So it is good not to take, right? It's causes another crisis. Next question, the rubella vaccine is contraindicated in pregnant mother because why? Or what are the reason? Rubella is live attenuated vaccine, right? Answer is it can cause rubella in the infant because rubella can cross the blood-brain barrier and it is live attenuated vaccine. So rubella vaccine contraindicated in the pregnant patients because it can cross the placenta. We learned this information, right? So pregnant women should be advised to avoid pregnancy even after 28 days after immunization with MMRI. Another information. It should not be given during the pregnancy. However, the CDC has collected data on women who have accidentally received the immunizations while pregnant, and there is no documented injury to the offspring. Vaccine is safe for women who are breastfeeding, even though rubella virus is excreted in the breast milk. Next question, a 70-year-old male has yellowish triangular nodular near the iris. This is probably a stye, chalazion, conjunctival hemorrhage, or pinguicula. Okay. Answer is it is pinguicula, but I want to put some information here. We have to know what is stye, what is chalazion, what is pinguicula. So stye most of the time lower lid, and it is very painful. But most of the times I said, and it is painful. Like here showing the stye in the upper eyelid, it should be painful. Chalazion is most of the times in the upper eyelid, but it is painless. Okay, so same. So difference between stye and chalazion, location most commonly found at or near an near eyelash follicle. Chalazion most common found above the eyelash on the upper eyelid. Most of the times it is lower eyelid, but painless. Stye causes bacterial infection either at the root of the eyelash follicle or in the oil gland of the iris. Chalazion, a blockaged oil gland. It is called Meibomian gland. Symptoms, it is very tender swelling, but chalazion is firm, painless lump. Treatment, spontaneously drainage, warm compresses. Chalazion, it is warm compresses, antibiotic eye drop. If it is not okay, surgically remove. Here we can see a few more information about pinguicula. It's yellowish rays growth on the eye, particularly in conjunctiva. What is conjunctiva? Basically, clear membrane that cover quite part of your eye. So this yellowy, this one, yellow rays growth. Next question. What findings is the most characteristics of shingles? So patient complain pain, burning, and itchy. Single dermatome affected. So shingle is very painful, but we are not sure it is burning or itchy. But what we learned from this question, we learned shingle always affected single dermatome. What is single dermatome? The area, particular area supplied for particular nerve. Single is herpes zoster. So herpes zoster when in adult, it characteristically affected a single dermatome. Group vesicles on an erythematous based may occur in some patients with single, but this is not unique to shingle. In fact, it is typically in many viral infections, right? And crush may be seen with single chickenpox or impetigo as well. Pain, burning, itchy are symptoms that some patients have with shingle, but not all patients report itchy with single. There's some information about the herpes zoster infection. Patients who have the single are not able to transmit the single to other patient. Transmission of the chickenpox virus, varicella zoster, but herpes zoster can cause single and varicella zoster can cause chickenpox. So susceptible patient may occur with contact the patient with have the shingles. Another way I remember, most of the times varicella zoster in children, but most of the times herpes zoster in adult and causes the shingles. Next question, a patient who is 65 years of old, that she has hay fever and has had this since childhood. What agent could be safely used to help with rhinitis, with seizing, pruritus, or congestion, right? So from this question, let me figure out some point. Patient is 65 years older, right? 65. Hay fever since childhood, and also agents could be safely used to help rhinitis, sneezing, pruritus, and congestion. Also the nasal steroid, because this patient has an allergic rhinitis, not a congestion, but not a decongestant. Nasal steroid, considered the gold standard for improvement. So what we learned from this question, we learned the nasal steroid is considered gold standard for the improvement of all symptoms associated with allergic rhinitis. Also, antihistamine help all symptoms listed, but is not effective as relieve the symptoms of congestion as a nasal steroid. A decongestant is extremely effective at the relief of congestion, but no other symptoms. So at least steroid can cover all of the symptoms, right? Next question, a 38 years old male patient thought to be good health and also present to a primary care clinic. The routine exam, the patient fasting blood sugar 242 milligram per DL. Repeated value after eating 288 milligram per DL. which of the following least helpful? Initial evaluate this. You say that when you read this question, it is very important. It is talking about the least, not the most. If it is most, answer is this. But least answer is the non-fasting lipid. This is one is answer. So let me read it. Lipids should be done in fasting state. Lipid profile always fasting. Non-fasting is not significant that much. Triglyceride are especially sensitive to non-functioning state and will give a abnormally elevated value if performed in a non-fasting patients. Since the triglycerides are frequently elevated in patients with elevated glucose level, a fasting level should be performed. Also, initially, blood pressure, fasting, lipid, and microalbuminemia are critical to assess this patient diabetic status. So it is microalbuminemia important if patient has a long-standing diabetes, if it is affect the kidney. Microalbuminemia means albumin present in urine. Albumin is one of the amino acid. And blood pressure is important as well because it is a long-term effect. But fasting lipid is important, but not non-fasting. So next question, a 58 years old female present with a wedge-shaped, pinkish and clear growth on the nasal side of his eye. And he stated that, a 58 years farmer present with a wedge-shaped, pinkish, clear growth on the nasal side of the eye. And he stated that he has been present for a while, but only recently began to feel as if the foreign body was in his eye. So in this picture, you can see this is the eye growth in the membrane, right? This is, you see this one picture. So this is pinkish clear growth, nasal side in the eye. And patient said feeling foreign body in the eye. What is that? Is this style? But style supposed to be lower eyelid or upper eyelid, and it should be painless swelling. And it is, they said, pinguiscola, it should be yellowish growth in the nasal side in the conjunctiva. Xanthelloma, it should be outer layer because of the lipid or dyslipidemia. And the other one is called pterygium or targium or pterygium. So this can occur in the children, but it is more prevalent in old adult and associated with chronic sun exposure. The farmer, because of his profession, he has to work and chance to explore under the sun. It is a benign growth of fibrovascular conjunctival tissue that is usually appear on the nasal side first and extend laterally towards the iris. Although it is often initially asymptomatic, it can cause irritations and even visual impairment as it extends onto the cornea towards the pupil. A style is a painful, self-limited infections or a gland at the eyelid margin. Xanthelloma typically associated with hyperlipidemia, yellow plug on the middle aspect of eyelid. And epingocola is a benign yellow triangular nodule that does not affect the vision. So again, I want to tell you, this is, you see, a pink color growth that start on the clear tissue, the eye, called conjunctiva. This is the conjunctiva. The most common sign symptom. They said sometimes there are no symptoms. Symptoms when present include pinkish triangular growth on the cornea, triangular growth, irritating eye discomfort, patient said feeling foreign body, burning sensation, foreign body sensation, redness, blur of vision, and itchy eye. What are the next question? Next question here. A 3-year-old female had a fever, and fever is 102 degrees Fahrenheit for at least 3 days. Today, she woke up from a nap and is febrile. She has a maculopapular rash. So in this picture, we can see some kind of rash. It is maculopapular. Which statement is true? 3 years old, 102 for last 3 days, but today no fever, but still has a rash. What kind of infection it is? This child probably has measles. This rash will launch, but without anything, it will be disappear. This is staphylococcal rash, or this could be Kawasaki disease. So this describe a patient with a roseola or eczema subitum. This is a common viral eczema found in the young children caused by human herpes virus 6. It is characterized by high fever for 3 days, followed by abrupt cessation of fever and appearance of maculopapular rash. This usually resolves in a few days, and child may return to school or daycare while has been fever free for 24 hours. So this is called roseola, right? The roseola most common presentation, this roseola most common presentation, we said high fever for 3 days and then cessation of fever, and also see maculopapular rash. This is maculopapular rash, characteristics of roseola. We are going to talk about the overview about roseola. Is a common infection that usually affected children by age of 2. It is caused by a virus that spread from person to person. It can cause high fever followed by rash that does not itch. About a quarter of the people with roseola get a rash, and some book also say roseola is called 6 disease. So it does not, it is not a serious condition, and it does away on its own in a week or so. Treatment for roseola include cool cloth or medication to reduce the fever. What next? A 16 years old complained that his knee hurt. His mother stated that he has complained of knee pain for past 2 weeks. And he has a prominent tibial tuberosity. So in this picture, this is the tibial tuberosity and the lump below the knee, swelling, knee hunt, tibial tuberosity prominent. What should the part of the differential diagnosis? It is Osgood'S disease, growth pain, acute lymphocytic leukemia, and psychogenic pain. The correct answer is Osgood'S disease. Osgood is osteochondritis. So this area, bones and chondrium, so it's called osteochondritis, inflammation of the tibial tubercles that can produce the pain in the knee of adolescents. Pain gradually increases over the time and can become severe, especially if the knee sustain a direct hit when patients need. And this diagnosis can be made on clinical presentations without the need for imaging studies. And this is usually treated by rest or put to the ice or heat, non-steroidal anti-inflammatory or NSAID, also strengthening the quadriceps muscle. Activity should not be stopped, but instead slow down if possible, right? Or if symptom. So there are a few more information about the Osgood-Slater's disease. Also, it is known as osteochondrosis, right? Inflammation of the area just below the knee, causing the pain. In case of Osgood-Slater diseases, especially in the growing children, it usually occurs in children who participate in sports that involve running and jumping, such as scooter or basketball. In this picture, we can see this area, pain below the elbow, right? Or pain below the knee joint is Osgood-Slater disease, right? And here is a pain above the knee. This is quadriceps tendon swelling. Next question. The laboratory identify metamyelocyte in 50 years old patient who had a complete blood count performed. What might be an expected findings in this patient, right? So a patient came to you and after laboratory test, particularly CBC, you found metamyelocyte, right? So what should be the presentation for this patient? In this histopathological findings, we can see the metamyelocyte in the center of the picture. So the presentation is splenomegaly, number B, elevated liver function test, decreased uric acid level, and decreased platelet count. Answer is splenomegaly. The findings of metamyelocyte is an ominous one. This present immature white cells that are usually present only in bone marrow. The examiner should consider a diagnosis of leukemia. A definitive diagnosis can only be made after the bone marrow aspirate and examine. Many adult patients are asymptomatic for months before diagnosis. Splenomegaly and hepatomegaly are common because excess neutrophil produced by the disease of the bone marrow. So my patient age is 50 years old, and this patient may be considered diagnosis of leukemia or blood cancer. At the very beginning, present the presentation, and if accidentally found in histopathology, we will say metamyelocyte, and patient maybe have a spleen getting enlarged, liver getting enlarged. It is called splenomegaly, or sometimes hepatosplenomegaly. Next question: what advice should be given to a patient who has a child with a fifth disease? So, as I told you, every question is a new information that we are going to learn. We are going to talk about something about the fifth disease. Advice should be given. This commonly causes pruritus and in the young children, means itchy. It can return to the school when rash has disappeared. Acetaminophen could be avoided in this child. Number 4, parents may experience patient experience the joint ache and pain. So fifth disease patient present with joint pain and inflamed joint. So fifth disease, erythema, other name erythema infectiosum. Fifth disease is a common viral infection in the children 5 to 15 years old. My patient is do not mentioning here. This produces a maculopapular rash. This is maculopapular rash in the face. This is maculopapular rash in extremities. And the rash that launch easily. This rash is not pruritic. It does not cause itchy, but may last for 7 weeks before it completely goes away. Children are allowed to attend school as long as they have been fever-free for 24 hours. Discomfort of illness like fever, body ache, like example, this explains joint pain, and also treated with a acetaminophen or ibuprofen because of fever. Adults who are exposed to children with fifth disease may complain of arthralgias and myalgia, means muscle pain, joint pain, for several weeks. So, next,